It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying the continuous popliteal approach to the sciatic nerve. The continuous popliteal approach to the sciatic nerve is used for postoperative pain control following major foot and ankle surgery, and it is almost always necessary to combine this block with a continuous femoral nerve block, which will cover the medial aspect of the lower leg and the medial aspect of the ankle and foot. Please note that the saphenous branch of the femoral nerve down to and including the ankle joint supplies the medial half of the tibia. The intended positioning of the tourniquet helps to choose between this block and the subgluteal approach. The sciatic nerve innervates the lateral aspects of the lower leg, the lateral part of the ankle, and the entire foot with the exception of the medial part, which is innervated by the saphenous branch of the femoral nerve. It is the preference of this author to use 15 to 40 milliliters of ropivacaine 0.5 to 0.75% or bupivacaine 0.5% for the initial bolus of this block. This is followed by a continuous infusion of 3 to 10 milliliters per hour of ropivacaine 0.2% for postoperative pain management. Patient-controlled bolus injections of between 5 to 10 milliliters can be allowed every 60 minutes. The patient is positioned in the prone position with the knee slightly flexed. The tendon of the biceps femoris and the semimembranous muscles are palpated and marked. These tendons usually meet to form the apex of a triangle, of which the basis is the skin crease behind the knee. A line perpendicular to the basis line of the triangle is dropped from the apex of the triangle, and needle entry is slightly lateral of this line, 7 to 9 centimeters above the crease. The skin and subcutaneous tissue, as well as the intended path of tunneling of the catheter, are anesthetized with a fine needle and lidocaine with epinephrine 1 in 200,000 solution. A 17 or 18 gauge insulated TUI needle is attached to a nerve stimulator set to an output current of 1.0 to 1.5 milliamps, a frequency of 2 Hz, and a pulse width of 100 to 300 microseconds. The needle enters the skin at an angle of approximately 45 degrees pointing cephalad and the bevel pointing upwards to facilitate easy catheter placement. It is advanced until the sciatic nerve is stimulated. The tibial component of the sciatic nerve is indicated by brisk plantar flexion motor response at a nerve stimulator output of 0.3 to 0.5 milliamps. This indicates accurate needle placement, but not necessarily accurate catheter placement. Do not inject any local anesthetic or saline through the needle at this stage. The notion that the space can be opened with normal saline to make catheter advancement easier is not based on scientific fact, but rather on fantasy. Saline injection at this stage only serves to make the tissue edematous and to make further nerve stimulation through the catheter impossible or very difficult. The stylet of the needle is removed. The nerve stimulator is attached to the proximal end of the catheter, and the distal end of the catheter is placed inside the needle shaft. Hold the proximal end of the catheter in the palm of the left hand. The broad black mark on the catheter indicates that the catheter tip is at the tip of the needle. Advance the catheter. If the motor response stops, it simply means that the catheter is moving away from the nerve. Carefully withdraw the catheter to inside the needle shaft again, rotate the needle a quarter turn clockwise or counterclockwise, and advance the catheter again. If the motor response again ceases, withdraw the catheter again to inside the needle shaft and advance or withdraw the needle slightly before advancing the catheter again. Repeat these maneuvers until the motor response remains positive and brisk during advancement of the catheter. Make sure that the catheter is always withdrawn to inside the needle shaft, that the broad black mark on the catheter is always visible before the needle is manipulated. The catheter can be advanced for 3 to 5 centimeters along the nerve. Advancing it further than 5 centimeters may cause the catheter to coil up and even coil around the nerve. This has never been described, but it is a theoretic possibility. Remove the needle without disturbing the catheter. If the catheter is now left in this position, it will almost certainly dislodge, and it should be tunneled subcutaneously. Tunneling can be with a special tunneling device or by using the available equipment. First, insert the inner stylet of the needle subcutaneously from a point 1 to 2 millimeters from the catheter exit site, if a skin bridge is required, to a point approximately 6 to 10 centimeters lateral. This area has been anesthetized previously. The skin bridge will make removal of the catheter easier, but a higher frequency of catheter leakage can be expected. The needle is railroaded over the stylet. The stylet is removed and the catheter is fed retrogradely through the needle. The needle is removed and the piece of silicone protection of the tip of the catheter during packaging is handy to protect the skin under the skin bridge. The snap lock is attached to the proximal end of the catheter and the nerve stimulator is attached to the snap lock. The motor response should remain unchanged. The nerve stimulator output is set to 0 and slowly turned up until the muscle twitches can just be seen. The local anesthetic agent or any other fluid that conducts electricity is injected through the catheter. In this instance, this fluid is normal saline. The motor response disappears immediately upon injection, which is a positive Raj test and a further indication that the primary and secondary blocks will be successful. The catheter exit site is covered with a transparent dressing to allow daily inspection. The snap lock and catheter are placed in the stat lock, which is in turn attached to the convenient place on the leg. The main dose for the block can now be injected through the catheter. Catheter removal is a sterile procedure and is after the patient does not require the continuous nerve block any longer and after full sensation has returned to the foot. The proximal end of the catheter is fixated with the left hand while the distal end is removed from the skin bridge. This distal part of the catheter is kept sterile and the rest of the catheter is removed. If radiating pain is experienced during catheter removal, this may indicate that the catheter is coiled around the nerve and extreme caution should be exercised. This eventuality is a theoretical possibility that has not been reported yet.